Hello, everyone. Thank you for attending. We will begin shortly. We will be starting at 12 o'clock on the dot. Thank you. Hello, everyone, and welcome to the first of CalHIPSO's educational webinar series. This webinar today is called An Industry-Wide Solution, IHA and the Statewide Provider Directory Utility, or PDU initiative. My name is Chloe Scholl, and I will be the organizer for this webinar. All the attendees will be muted for this session, so if you have any questions throughout our time together, you can submit them in the chat box, and if time allows, we will try and answer a few questions at the end of the presentation. Today's webinar is being recorded, and the recording will be available at www.calhipso.org in the following few days. I would now like to introduce the Executive Director of CalHIPSO, David Ford.
Thank you, Chloe, and thank you to everyone who has signed on to today's webinar. We appreciate you taking some time today to learn about what we believe is a very important topic. Since I know a lot of folks here on the phone probably have not heard of CalHIPSO before, I just thought I'd start with just a little introduction about who we are. CalHIPSO was originally founded in 2010 as a joint venture of the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. CalHIPSO was the largest of the 62 federally designated regional extension centers across the country. And in that role, CalHIPSO helped providers in California navigate the complicated world of electronic health record adoption and use. Even though CalHIPSO was originally formed to be the Regional Extension Center, CalHIPSO is currently branching out into many different areas. Some of our current projects include Medicaid Meaningful Use, QPP and MIPS in the Medicare side, diabetes data reporting, encounter data improvement, and health information exchange. Across all the programs CalHIPSO has done over the years, CalHIPSO has provided technical assistance to over 13,000 eligible professionals, spanning more than 1,400 organizations statewide, and helping them earn more than $250 million in federal incentive payments. With that, I would like to introduce today's presenters right before I turn over the reins to them. So our first presenter will be John McBride, MBA, the Chief Technology Officer of the Integrated Healthcare Association. Mr. McBride is a business-focused technology executive who has spent 25+ years working in technology endeavors, startups, and innovative healthcare teams. He currently leads and builds critical systems as IHA's Provider Directory Utility CTO and the founder CTO of Sunfish Health. Previously, Mr. McBride has worked in various roles in healthcare and other technology, working at companies and ventures including Lockheed, NASA, St. Jude Children's Research Hospital, and Johns Hopkins. Our other presenter is Rajan Shah, the Vice President of Business Development at Gain Healthcare. Mr. Shah currently serves as the his primary focus is centered around healthcare organizations, both payer and provider alike, looking to expand upon master data principles and healthcare interoperability. In the past, Mr. Shah has served in various roles as Information Technology Director over Clinical Applications and Innovation. So, with that, I will pass the microphone and the presentation over to John McBride. John, take it away.
All right. Thank you very much, David and Chloe. I'm going to test this out, make sure I can move forward. There we go. So hopefully the screens will update, but if any issues, please let me know. So as I mentioned, thanks for having us today. We're excited to share what we're doing here with the PDU and how it impacts, hopefully everybody positively in California. My plan, I'm going to switch one more slide here. Stand by. Yeah, so the plan here is I'm going to give an overview, a little bit of background, if you will, about what we're doing, kind of why and how we plan to roll out this PDU statewide. Then I'm going to turn it over to Raj, who you just introduced, and he's going to really dive into the details, go a little bit deeper into the PDU itself and highlight the technology and really how it can help you work through specific workflows and also meet compliance and regulatory requirements. So we'll wrap up. The plan is to wrap up with some ideas on how you can get involved, and then hopefully we'll have some time for Q&A. So there we go. So first, a little bit about the Integrated Healthcare Association. So we are a nonprofit organization. We convene industry stakeholders, really across the board. So it's a diverse set of health plans, provider organizations, purchasers, and regulators to really solve the complex healthcare issues. So there's lots of areas to compete, but we work on those areas where collaboration makes more sense. So it really lets us tackle issues where we can drive consensus, meaningful action in healthcare, and again, hopefully you see those positive effects downstream. So IHA has led a number of performance measurement and benchmarking initiatives. So you might be familiar with value-based pay for performance programs or the cost and quality atlas, but we also work on other initiatives and focus on workflows, process improvements across the industry, and that's really where this provider directory utility falls. So making sure my little bit of lag on the screen there, so hopefully it's moving forward. Just to give you a little bit about how we got where we are, a little bit of the timeline. We're getting really busy right now, and we're happy to share where we are. But the timeline actually goes back in time a little bit and kind of started with what's called Senate Bill 137. So it's kind of the genesis of the law that requires us to focus on making sure that provider directories are accurate. So we're focusing on simplifying the management of provider information for providers, but we're also focused on making sure that we are compliant with all of the regulatory bodies that are out there and people who are looking at what we're doing. So the Affordable Care Act, just looking back a little bit, it sort of magnified an existing problem. The issue that more and more consumers are making healthcare coverage decisions based on inaccurate provider data. So this is really what led to the law being passed. So the idea is, if we can make the data better for the provider directories, the end result should be better decision making. Certainly these things impact finances as well, but we want to make sure that we're providing as accurate of information as possible. I want to point out that we actually, this PDU and IHA, and you'll hear more from Raj, but we're focusing between the health plan and the provider. So we're not actually making a solution for consumers or patients or health plan members, but everything we do should impact them positively. So all of the processes we put in place and what you'll hear about should create a better record that can then create better directories that consumers will use. So that's our goal. One thing as part of this timeline is you'll see there was a request for proposal back in 2017 that IHA led after being selected to run this whole process. And we selected Gain and Availity as sort of our technology partners. So they're very part and parcel to what we're doing, and kind of leads us into where we are today in 2018. We're in the middle of a soft launch. And that's really just the ability to take at a small scale, so a small number of users, and test out the functionality, make sure, again, we're hitting the regulatory compliance requirements, but also the functionality is usable. We understand the problems in more depth, and I'll share this with you in a little bit, but we have some data coming back as well from this soft launch. And then the goal is to have a production launch date in 2019, so very early. And we'll cover that here in a minute and how people can get involved if they would like to. So, yeah, so IHA is basically just to give you the role and what we're doing with our partners here. But we're facilitating this PDU initiative with a grant from Blue Shield. So working with Gain and Availity, we're responsible for building the data infrastructure, the workflows that ensure we're meeting the data standards. We're measuring and reporting the performance, which again, I'll share with you here in a little bit, some of the early information. We're also responsible for the rollout over the next 5 years. So it's going to be, it's not something that's fixed instantaneously. This is going to be a process where our goal is to make a self-sustainable tool for the whole state of California. We've heard that we need to achieve critical mass in order for this initiative to be successful, and we wholeheartedly believe that. We need to get more providers and more health plans to participate, and it's really it's a thing where the more people that participate, the better we'll be able to do. So we have a big job to do. I like to say that we're not in this alone. We have the entire state, lots of different participants that are helping out. So if you're listening right now, if you're part of a health plan, if you're a vendor, even if you're a provider out there, the regulator, certainly, we're all on this team together. So this is going to be a team activity. We also are, so we're building the infrastructure. And again, I mentioned this and I'll mention it several times, but we'll be meeting the requirements of SB or Senate Bill 137, but we're also focused on other state, Medi-Cal and also, CMS requirements. So when we talk about regulatory, we are focused on SB 137. It's actually, one of the more detailed or strict bills in the country. And so meeting SB 137 will also be meeting and making sure that we meet other regulatory requirements as well. So that's important. I think what we do here in California can certainly be something that the information, the lessons that we learn can be used all around the United States. So another important piece, and we're doing this right now, is outreach and recruitment of plans and providers as we move forward. So that's going to be important, and getting the word out. And what we're thankful for CalHIPSO is being able to share this information broadly, make sure everyone knows what we're up to with the PDU. Gain has a lot of experience, the vendor that you'll hear from in a minute, but they have a lot of experience in California, and they already have a strong base of technology and users that we're really lucky to be able to build upon. Move forward. Yeah. There we go. Yeah, so not to belabor the point here, but we also have market research that tells us that the process we're talking about, the provider directory process, is really very manual and inefficient today for both the plans and the providers. So it's not for a lack of trying. I mean, everybody, I think, is trying hard to update the information, but we're not seeing the results we want. So it's kind of highly inefficient. We're putting a lot of effort into the provider directory, but we're not getting the results out of it that we want. So there's kind of a good news, bad news there. I mean, everybody wants to fix this, but to date, there just hasn't been a platform or an initiative for everybody to work together. But if you look at what we're doing today, each plan requires its own format. The provider office may get a lot of phone calls asking to update, probably emails as well. So you're getting a lot of requests to update your information. You may answer that and then not see anything change based on your response, and vice versa. So we heard this from both sides. But some provider data is easily validated, like NPI, when we look at this, but other information like provider name, languages spoken, or even accepting new patients can be more subjective and contain a lot of variation. So there's just a lot of information, as we look out there. But we hear kind of similar issues on either side of the problem. So that's what we're focusing on. Switch forward here. Try to. There we go. Yeah, so what you're looking at here is just, kind of a visual representation of our vision. And, I always like to say it's really, we're setting up a sort of the future state versus the status quo or the current state. But this is where we feel like we can help is if you look on the left-hand side, it's really kind of a mess that I mentioned about different formats and, different timing. Basically the communication is a little bit ad hoc. And again, it's not working. But we're kind of in the middle arrow right now. We're moving towards the future state. We're making good progress. A lot of work to do. This is not going to be easy, but it's something that working together we can get to this future state where we have a California statewide utility. And the idea is that the database or the central part there can communicate, the source of truth. So the providers that are out there, the health plans, other entities can actually access the statewide utility and update this statewide utility and have some sort of comfort that when they update this, it's going to remain updated, it's going to remain correct, and it will continually improve as we use this central tool. The point-to-point on the left-hand side, again, is just, it's not scalable, and you have a lot of different various records that don't match. So the information, not surprisingly, is not correct today. And this is a picture, by the way, that was sort of our theory, the thesis, what we believed going in. So we drew this before we had data, but we're going to actually show you a little bit of the data that we're seeing here in a second. So if you look, again, our approach to data accuracy and quality is different, and we believe this is very important. But you'll hear this a lot, I guess, at the national level about, and I even mentioned it, data accuracy, and that's very important. But I think what we're really focused on is the data quality. So data accuracy, depending on how you define that, there's a lot of different ways that we can think about it. And that's not helpful when we're trying to make repeatable processes and get the information as accurate as possible. The data accuracy relies on the quality of both the field level data, the various different contract level information, provider level information like NPI. So there's a lot of details, I guess, the devil's in the details, as they say. So we're approaching this a little bit differently where, by getting a process in place right now and looking at the details, we can put, a lot more quality control at the field level. And this is ultimately, I think, something that we can export. So we can do this in California, we can use this around the country, but our approach at this kind of field level information is sort of what impacts those end users at the end of the day. So if there's a incorrect status for accepting new patients, if there are providers missing from a plan network, each one of those things has an impact, downstream on the consumer. So we're looking at each one of those workflows as something that we need to tackle. So each one of these sort of has an action item and something that we can do to, move the needle, if you will. So we're working towards a more streamlined process, but again, lots of work to do. Move ahead here too and give a few more details about the soft launch itself, the participants. Just have a little lag on the screen. Okay, there we go. So yeah, when I mentioned the soft launch, so we started about a month ago, and this soft launch, as we call it, is going to last through the end of this year. We're working with Blue Shield, HealthNet, and Anthem. So we have some large health plans, but we're also working with a handful of providers, provider groups, and independent practices. So this also includes 2 FQs. It's working. We have some providers in Southern California. We have some up here in the Bay Area, up in the north. So we're trying to get a good coverage, I guess, of different types of providers, different size of providers, and make sure that they're working, with the health plan. So we're right in the middle of being able to put the functionality we're talking about and exercise everything that we're working on in the technology is, working in the mode that it's going to have the greatest impact. So I'd say right now, 2018, this soft launch is more about the functionality. So it's more the scope. And then as we start to move back into 2019, that's more about the scale. So we're also focused on meeting people where they are, meaning if you have a lot of technology or if you have very little, wherever you are, the technology, the workflows, everything that we have will meet you where you are. If you have some kind of format, some kind of software system, that's okay. We're going to come out there and make sure we can plug you into this system however we need to. So I'm sure we have a lot to learn there. It is, again, a lot of work to do, but we feel like this is the best approach. So we can work towards standards. There's a lot of, the idea of standards and interoperability, and that's fantastic, and we're headed there, but we're not satisfied to wait. So we'll meet you wherever you are, I guess is the message. So yeah, going in, this is a pretty interesting slide, the baseline statistics that we have. It's a little bit of good news, a little bit of bad news, if you want to look at it that way. But I think that having the real data, the actual information that we're looking at right now, this is aggregated data, but it helps us because number one, I mean, the theorization about the inefficiency is correct. So that's kind of, looking at some of the numbers confirms that. There were a few things that they're not noted here, but there were some silver linings where some of the data that we're looking at is good. But I think the important part again is that we're able to take each one of these data elements and start to look at the data quality in detail about, number one, what is the impact that, the data we have has on the patients, on the members or consumers, and what can we do? Like, what are the actions that we can take to impact that? But if you look here, this is again aggregated across our entire soft launch. So just over 30% of practitioners are not listed in health plans online directory. So they should be, in other words. And that's a pretty big impact when you're looking at about a third of the practitioners. You might have consumers out there, again, looking at this information to make decisions, hoping a doctor is on the provider directory, and they're not listed, so they might make a decision based on that. But in reality, they actually are. So again, this is kind of one of the higher impact numbers, but there are a lot of things, and I know Raj will go into some more details in a second, but there's a lot of things we can do to impact this. And then sort of the other way around, there's 12.37% are listed, but they should be termed for various different reasons. So that's again, just another source of inaccurate information or low data quality. And then also just looking at something like status, 7% of the practitioners, have the wrong information. So again, back to the impact is the consumers are frustrated with this. They're looking at, they find the practitioner, and this is, it's a low number, I guess, to us in some ways, but it still has a high impact because if you're looking for a provider and you find them and it says they're not accepting new patients when in fact they are, or the information is incorrect, that's going to lead to, again, kind of a high frustration level. So everything we do, we want to try to make an impact. These are just some of the numbers we're looking at. We have several of them, but we wanted to kind of give you a highlight. One of the silver linings, I think, is like the NPI, the variation there was less than a percentage point. So that, there's several reasons for that, but that was kind of nice to see that there's beginning to be alignment, I would say, on some of the data that we're looking at. So I'm going to hand over to you, Raj, and I'll let you take us into some more depth, and then I'll try to wrap us up at the very end here.
Great. Thanks, John. I'm going to go ahead and make sure this is all working here. So just to kind of reframe up some of this and take it back a step before I jump into the technology and the process and the way we handle certain scenarios, I just want to kind of go back and look at, we saw that slide at the beginning that talked about sort of how did we get to this place today. Over the past few years, there's been a lot of activity, everything from SB 137. Obviously, there's been standards published, requirements for a statewide utility. But when we saw this problem early on, we very quickly saw how the marketplace was reacting to things like SB 137. We saw that the doctors were getting more phone calls. There were more faxes to collect data being sent out. Provider groups were getting more of these rosters and Excel files, and they were being done in different ways depending on which health plan they were contracted with. And it was putting a lot of administrative overhead on the marketplace. It was asking people to do a lot more reconciliation, a a lot more frequently. But as we saw through various audits and continued issues from the consumers, the reality was that the quality of the information wasn't getting better. You know, if you follow some of the CMS audits, you can see that over the past couple of years, as they've been auditing various health plans, it's actually been getting worse. So the idea that we're all putting in more money, more effort, more time, but we're getting worse results, it kind of goes back to this quote, you know, from Albert Einstein about insanity, right? We're doing things over and over and over again and expecting it to get better, but the reality is, until we look at the underlying processes and what those processes are and how they're operating, we can ask people to do a lot more of the same, but we're not really going to fix the problem. So to kind of continue here, sorry, there's a bit of a lag, but so when we had to try to look at this problem and how we were going to solve it, we had to understand, okay, well, why is the process difficult? What's wrong with it today? And one of the things that we learned is that because the providers' relationships were so complex, the idea that we could go to any one particular place and ask, you know, a front office admin at a provider's office about all of their contracted relationships, all of the level of detail, is a flawed logic. The reality is that data lives in a lot of different places. There's a lot of different areas where information is being managed. And until you start looking at things more holistically across the marketplace and understand where do we need to integrate, where do we need to go to get the data, the idea that we could just call one person or just reach out to a single individual and get all the information wasn't going to work. The other thing that we started to very quickly realize was that each health plan was going to have their own process, right? We saw a lot of different processes occurring in the marketplace, and nobody was aligning to any one particular health plan process. And that's why we've kind of resulted in having lots of different processes. And for the provider and the provider community, that meant dealing with lots of different portals, lots of different ways of reconciling information, lots of different types of requests. And that also wasn't going to be sustainable. So we had to look at this more from a collaborative standpoint. We needed to look at how something like this provider directory utility was going to provide sort of a multi-stakeholder system where we're plugging in health plans and provider organizations and independent practices in a meaningful way that was going to be able to facilitate the right workflows and get everyone what they need in a way that was going to reduce administrative overhead across the entire marketplace. So why are the providers' relationships so complex? Why couldn't we just call a physician's office and get all that information? Well, the reality is, especially in a state like California, it's very common that providers are participating with lots of different provider organizations. They're maybe using a management service organization. They may be participating in an ACO. And through those relationships, they're getting contracted to health plans. And in some cases, those health plans are renting networks to other health plans. And the reality is that there's just so many different relationships that exist out there that you have to go where the data lives. You have to deal with the systems out there that already manage this information across the marketplace. And you have to look at how you integrate those in a way that allows us to manage the information from a day-to-day perspective. So let's talk a little bit about how the PDU is constructed. Again, we're a centralized collaborative model. We're looking at plugging in all the various entities that deal with providers, everything from hospital systems to medical groups to the health plans, but we're also bringing in additional information. We're trying to leverage things like reference sources where we can to validate very specific pieces of information. When you have a centralized model where you can plug all these folks into, then you can start to control things like standards. We can make sure that we can crosswalk all of the different data points into a particular way. We can look at what validations should we be putting in place across those data fields. What are the things that we're looking to do to more standardize information and get ourselves into a way where we're being more adherent with both state and federal standards. When the DMHC published, the 5 different accepting new patient types, we're able to deal with that in one place here, where if you're in your own model, you're really having to deal with all of the regulations, the standardization in your own bubble. What we're trying to do is do it in more of a centralized way, so that way we can reduce some of the admin that's happening across the marketplace. The other thing that's become also very clear was that in order to deal with a lot of the complexities of the legislation, of just managing provider data from a directory standpoint, is a lot of these different endpoints don't have all the right resources or the right capabilities to deal with some of that. So you start to see organizations who start to have to customize their own systems. They take credentialing platforms and they start to customize them to add new data fields that are needed for Medicaid reporting that they previously weren't capturing. You're having to make a lot of sacrifices and put a lot more resources towards customizing things just to deal with a particular problem. And when we do things in this model, we can start to alleviate some of that burden from happening out in the marketplace. The other thing that we're doing within this model that's really, really important is we're protecting the information. So one, we understand everyone's viewpoint of their data. Everyone owns their own data, but we're also protecting it from the perspective of making sure the information that's flowing amongst these endpoints stays in a bubble that really it needs to be. Information right now, as SB 137 came about, as folks started getting requests to collect data from their practices, that information was getting circulated out in the marketplace. It was going to a lot of third parties that the providers weren't always aware of. When you have a trusted model like this, we can control the flow of information in a way that's dealing with regulatory compliance, but it's also protecting the data from the perspective of the provider. The other thing that became very clear as we were building out this model was that there's not just one part of the solution. It's multiple components, because depending on who you were, you needed different things from the model. You know, if I'm a provider, I'd love to know that I could go to a single place, manage my information, and that information is going to get distributed to all of my contracted health plans, and I don't have to go deal with dozens of different processes. I'd also like to know that when I go do that, it's a trusted place where I'm not losing my information and it's not getting sold to other parties. Having that type of a model for an individual provider is extremely valuable. It's something that's been missing from the marketplace for a very long time. If you're a provider group, you needed tools to deal with some of the health plan reporting. You know, if you're the group of people that have to deal with the rosters that come to you from a health plan, you understand how much time and effort is being spent to reconcile that data, deal with those spreadsheets, sending those back to the health plan. You need some tools to alleviate some of that overhead. You also need to make sure that your internal systems are being linked up and that they're being kept in sync with information, that you have some additional layers to be able to verify certain pieces of information, and really just being able to be given the capability of managing this data from a day-to-day perspective. If you're a health plan, you really want, first and foremost, to be regulatory compliant. Compliance is obviously a huge part of this process, but as we also realize on the health plan side, it's also potentially very difficult to take all this data that's coming to you and ingest it into your system, making sure everything's kept in sync. So being able to link up your internal systems, your claims platform with your authorization platform, with your credentialing platform, was also a really big key. Because when you look at how online provider directories are created and look at how the data is being sourced from internal systems, it's sometimes coming from multiple places, and it may not always be in sync. And so having some of those capabilities on the health plan side allows them to better manage the information that what they publish in their online directories is more accurate. I want to talk a little bit about how the architecture plays a role in this and what the PDU really kind of looks like, because as I mentioned before, we've got these different value propositions depending on who you are, and that also means and translates to different utilities within the PDU itself that facilitate some of those capabilities. So from a front-end perspective, we've got a portal where an individual provider can go to manage information. They can see a level of detail that's contract specific. They can see what networks they're participating in. They can manage their profile, make updates to their profile. Underneath that are some bigger capabilities. So we have what we refer to as our data registry. The data registry for us is a place where we can maintain validations, business rules. We can maintain standards and crosswalks. We can ensure all of the necessary moving parts that need to be put in place are there so that we can actually manage the information. We also understand that there is this concept of large provider group roster exchange with health plans. And we are in a position when we start plugging health plans and groups into this model to start facilitating a more streamlined way of exchanging large volumes of data that alleviate the health plans and the groups from having to deal with processing, bulk files. So the way we handle that through the PDU is meant to be a future way of doing things where we can really sort of reduce down administrative overhead of processing that information. Similarly, there's also this concept of attestation. So SB 137 brought this into play. If you look at Medicare, they've got something similar where they talk about quarterly outreach. And the reality is that we need to have a way of facilitating a point-in-time review of information. So within our model, we're able to facilitate contract-level review of information between a health plan and all of its downstream contracted provider network. From a back office perspective, we've got a couple components that help us manage this from a day-to-day perspective. We bring in reference data that helps us do certain validations within the data registry component. We've got data stewards who spend a lot of time combing through information, ensuring things are lined up properly, looking for anomalies, trying to find validations that may need to be additionally looked at. All those things that are very much a day-to-day perspective. And all of that falls under an umbrella of an operations team that is really working every day to ensure that the processes and the workflows that we've established are all in place and they're working as they should be expecting to. And so from a user perspective, as a physician or a provider, you may see just the portal, and that may be how you interact with the utility. If you're a group, you may be looking at things a little bit differently because you're exchanging larger data files within the PDU. And similarly for your health plan, your interactions may even be deeper because you're dealing with file exchanges and portal and potentially some additional components. So everyone's got a little different perspective of how they see the PDU and how they interact with it. And if you kind of look at that from a day-to-day perspective, and we take it a little step further, we can see where people interact with this process. Again, the provider interacting with the portal, they can manage their profile, they can still get things like notifications. If you're a provider organization, you've got the capability of dealing with things more from more of an IT technology background where you can send large data files through an FTP process to the PDU. But you also still can deal with things from a portal perspective because you also need to be getting things like notifications that tell you about discrepancies in your data, things that need attention. If you're a health plan, you're dealing with all those things as well. And you're also sending data files, you're dealing with notifications. You may be also dealing with some things like your electronic online directory. All of those things mean that people have different ways of interacting with the process. But what it means from us, from a PDU perspective, is that we had to build in the right workflows depending on who you were. Because the idea that everyone would interact with the PDU in the exact same way wasn't going to happen. We really had to cater to the variety in the marketplace, everything from multi-thousand provider MSOs down to individual sole proprietors, all the way up to very large health plans. So all had to be catered for in this particular process. I'm going to go through a couple of different scenarios that I think were interesting. It's workflows that we've had to look through and go through within the PDU process. The first is just a very simple, very common thing that may happen, which is the adding or removing of a provider from a network. So you may have a small practice that's contracting with a provider organization, and they may also have some direct contracts with the health plan. they need to make an update, they need to add or remove a provider. So how do we communicate that out, right? Within the PDU process, they may go into our portal, they may make those changes there. Those changes then need to then get communicated downstream to multiple parties. So we have to start facilitating various workflows. In the case of the large provider group, which has an HMO contract under the umbrella with this particular small practice, we need to make sure that information flows to that provider group. That provider group still needs to review it, needs to make some adjustments to their own data, and ultimately then within their data files being sent to the PDU, they can make those changes and submit that information. But at the same time, we also need to make sure, because there are, direct contracts that this group has to the health plan, we need to also be able to communicate that directly to the health plan. And so through the portal and through the extracts that we provide, we can also make those communications available. And the key being that we're starting to facilitate these communication workflows to ensure that all the right people are told about a particular change and that the right actions can be taken subsequently because of that. Now, we understand that in certain scenarios, like maybe they're adding a provider, there's some additional layers to that process that the PDU in itself may not cater to day one. You need to submit paperwork and a W-9, and there's credentialing information that has to go out. But the big thing is that we're in a position to start minimally making sure the communications are there. And downstream, as we look towards the future of the PDU, where we're able to start interjecting ourselves and enhance the process to maybe start reducing some of that additional layer and pulling it into the PDU, it's something we want to look at, something to look at how we can enhance our process to start to reduce down a bunch of that overhead that really already exists today and generally very manually done. Accepting new patients. Again, very common situation. You have a provider who is saying, hey, listen, I need to close my panel. I can no longer accept new patients. Well, that workflow is extremely important, and it has to take into account those contracted entities, those two contracting endpoints who are really responsible for managing this information. In this case, if you've got a provider who may have a direct PPO contract and they may also have an HMO contract through, let's say, an IPA, if they want to make a change to that status and they want to do so across all of their contracts, well, we've got two different workflows here. The first workflow being on that PPO contract, we can release that to the health plan because that's directly between the provider and the health plan. And that's a piece of information that can be communicated immediately so that the health plan can take action on that particular contract. Subsequently, on that HMO contract, that's really between the IPA and the health plan. So when the provider wants to make that change, we can't just go tell the health plan on that HMO contract, go ahead and change that status. We really need to make sure that goes to the IPA for review, whether the IPA then can check against its own contractual terms with the provider, make the determination or whether or not that's an acceptable change. And if it is, we then can make sure that that flows to the health plan. I kind of consider it more of the data chain of custody, making sure the information flows to the right people at the right time so it can be reviewed, and we don't break a process where we maybe skip over an endpoint that needed to be involved in the process. The next big thing was looking at large contracted network reconciliation. So as John was looking at earlier, we were seeing some statistics about providers missing from a directory or providers needing to be removed from a directory because they're not part of that network. Well, those numbers are pretty high in general when you start looking at those volumes. And the reality is that that's a big problem. If you're trying to validate lots of other pieces of information, you first need to make sure your starting point is correct, that the universe of providers that you're even looking at is the right universe of providers. So within our model, we're able to start doing some of that because we're plugging in large provider groups and we're plugging in health plans. We're getting data on a regular basis from both of those different endpoints. We're now in a position to start looking at all that data, doing that comparison, and starting to figure out where do we have agreement and disagreement of that information, and being able to communicate that back to both the provider group and the health plan so we can start facilitating a reconciliation workflow. As we start to do that, then we can get consensus on the universe of providers, and then everything else we're validating becomes even more meaningful. this workflow right now, which maybe seems very similar to like a roster exchange, but those roster exchanges are not happening all the time. Those are happening generally on a quarterly basis, maybe even less frequently with some of your contracted health plans. When that ends up being the case, you end up waiting for a long period of time. You go through it, you realize, oh, there's a lot of discrepancy here. You maybe submit those changes, then you have to wait a quarter, and you have to hope that everything's went through. And you don't really have visibility into it because you maybe don't know. You maybe have people spot checking an online directory, checking to see if those updates flow through, but it's a process that has a lot of lag to it. And even when it has lag, the next time around, you realize it's still wrong. Well, now you have to wait to another period to figure out, is that information getting reconciled? And it just perpetuates itself to being very far behind. But when you plug everyone into the centralized model and we're getting data on a regular basis, there's no reason why we couldn't be doing that reconciliation on a more frequent basis and being able to communicate that out properly, facilitating those workflows so that when it comes time to do something like an attestation process, attestation shouldn't be where we reconcile information. If this is happening on a regular basis from a day-to-day perspective, attestation should be more of a review saying, yeah, my information is correct. Everything does look good because I've been managing it through this process from a day-to-day perspective, and I don't really have any discrepancies when it comes to that point. But right now, we're not seeing that because there's a lot of workflows that are extraneous, they're lagged in time, and so we end up having to use attestation as a potential time to do that reconciliation. We're really about seeing how we can facilitate that from more of a day-to-day perspective. With that, I'm going to go ahead and turn it back over to John, who I think has some final closing remarks here.
All right, thank you, Raj. And I think everyone can get a sense of how important understanding the details, the deep details of these workflows are between all the all the different players. I'm going to try to. There we go. Yeah. So before we get into the Q&A, just a couple of quick points. Again, reiterating that right now we are in the middle sort of the soft launch. Here as we are in Q3 of 2018. So you can see that, and I guess the point is, if you can hear my voice, if you're on this call, if you care about helping in any way, so if you're a player that has impact or is impacted by the provider directory information, we'd love your participation. We will finish the soft launch. We're on target and on time right now, but by the end of this year and early in 2019, we want to begin the rollout. But I guess one thing that I can answer is, what can you do right now? And I'm going to pull up the next slide here, I think. There we go. So, yeah, I mean, right now, we'd love to hear from you already. Again, wherever you're at, whatever you're doing, you can go ahead and sign up for updates. This helps us as we plan for next year, as we plan the rollout. I can already tell you that we want your involvement. So, please go to providerdirectoryca.org. You can certainly send an email to pduinfo@iha.org as well. And we can begin planning, sharing information with you on both where we are in the soft launch, but also how you can kind of get in the queue to come on board in 2019 when we roll this out. And I can't emphasize enough just how excited we are to be able to bring this to California with everybody's participation. And thanks to David and Chloe again for letting us share this information. And I think we'll jump into Q&A next.
Yeah, thank you very much, John. Okay, so now we're going to get into our Q&A portion. We've had a couple questions come in during the presentation. The first question is from Janet. I'm just going to say V. I apologize. I can't pronounce your last name, but her question is this for covered California or all programs and products? For example, Medi-Cal, commercial HMO, senior, or even PPO, and whether the provider is contracted direct with health plan or through an IPA. She said also TRICARE, question mark.
Yeah, so this is for, Go ahead, Raj. I mean, I was going to say this is for everyone, but Raj, if you want to answer the details, that'd be great.
Yeah, so within the model, we're catering to all lines of business. It's not just SB 137. We have to deal with Medi-Cal requirements. We have to deal with Medicare requirements with CMS. I know from the Covered California perspective, we're actively engaged in conversations with Covered California because they are an important part of participating in this process. So we're definitely looking at this holistically across the marketplace. Even things like TRICARE play a role in this, and we understand the reconciliations that have to happen with that as well. So they're definitely all part of the ecosystem. And I don't know, John, if you had any additional words on that.
I think you hit it. This is, we're trying to include everybody. There's certainly a planning, kind of a timeline and methodology we'll have, but this is meant to be kind of a central source for everyone.
Great, thank you. So we've had a couple questions come in about costs associated with the providers. Can you touch on that?
Yeah, certainly. So, one thing to say is we're still working out the exact business model, but as we go into 2019, we plan to have those who get involved earlier as part of a sort of highly subsidized approach. So there's details in here, but just to answer a couple things, we don't want price or cost to the providers to be a barrier. So those like independent type practices, maybe, for example, there's no cost or charge to them. But certainly as you kind of move up the value, there will be a cost or a price as we move in, even beyond 2019. But those are details to work out. As I mentioned, IHA is a nonprofit, and we're looking at this more as a utility. So we want to make sure that the barrier, the entry cost is very low. And we want to make sure that the value represents, the price according to who you are sort of in the network. But we'll have more specifics on costs and so forth as we move into next year. But I guess the summary is, we just don't want price to become a barrier to this.
Great, thank you. So the next question we have is from Sam Goodwin, and his question, or she, is can you give a specific example of the kind of reference data the PDU would manage? Would it be like a number of physicians in geography? Thank you.
So when we talk about reference data within our model, we're talking about using potential sources of truth of information. So when we look at something like an NPI number, we want to use NPES, which is the source of truth for that. State license data, we get data from the medical board. Board certifications coming from things like ABMS. There's a lot of different places where there are very particular sources of truth, and we try to pull all those in. We also try to use data from CMS for facilities and hospitals. We use OSHPOD for standardization with hospital naming within California. We use NUCC for taxonomy information for specialties. We try to plug in as much of that into this model so that when we are processing data, we can bump things up against those sources to see are they aligned with them. And if there's additional information coming from those reference sources, we want to be able to pull that in. So when we find a state license number tied back to the licensing board, we can then pull in effective and expiration date. So we can start to see, do we have any problems where you may have providers who have expired licenses or delinquent licenses. All those things play a big role on top of everything else we get from the payers and the provider groups and small practices. It's all very much part of that ecosystem.
Great, thank you. We have another question from Jenna Christensen. Her question is, are there metrics/goals to hit for the provider attestation percentage once rolled out?
A good question. If you want to go ahead, John.
Yeah, I was going to say, as we work on goals, and I'll hand it over to you, Raj, here in just a second. But, we do have targets that we're aiming for. A lot of what you just saw was, kind of the initial baseline data. So we're starting with a baseline of where we are today. And so we have things like non-responsiveness. There's reasons for that. We see data that's updated, but it's not reflected. So we're kind of at a point where we're getting the baseline. The goal, like if you look at the law, is everybody needs to sort of comply and attest when they're supposed to, et cetera. So the SB 137 in this case has some teeth, I guess, that can hopefully help us move upward on that number. But it's certainly something that we want to make a workflow that's efficient, where you can update information, you can do the attestation, as Raj said, as part of the process that you do, so it's not such a big event. But just to answer specifically, I mean, the goal is to move it as high as we can, but we're basing the actual numbers to answer that on the baselines. So Raj, if you want to add to that, please do.
Yeah. So the only thing I'll add to it is, I think when people think about attestation and they think about things like Medicare requirements, about outreach to the providers, everyone kind of goes after the golden 100% full compliance, everyone's attesting. But there's a reality that is, one, some providers are not going to attest, and that's going to happen. That's going to be a scenario. But also, alternatively, there really is no 100%, because there are going to be providers within, let's say, a health plan network that shouldn't be attesting. Maybe they've retired or they've passed away, and so your actual number of who should be attesting, you don't get a good sense of that until you start that process with any one particular health plan and all of their contracted network. So to John's point, we need to get some baseline data statistics going so we can figure out, first of all, what is the real universe of providers that should be attesting? And once we get down to that, then we start to look at how do we improve the attestation rate within that particular network. And I know from Gain's perspective over the past few years, having done this with some of the health plans, we start to realize that there's certain mechanisms and ways that provide better adoption of attestation, getting folks into that routine, getting them familiar with the process, giving them some tools that allow them to very quickly and easily go through an attestation was very critical. How we communicate and educate the provider community also helped with the adoption rate. I mean, clearly we want to get to the highest percentage possible of attestation, but there is a percentage of the marketplace that just won't align with that. And until we get into those details with any one particular health plan, we really don't know what that number truly is.
Great, thank you for that answer, Raj. So we're going to wrap up the Q&A portion of our webinar, and I'm going to head it back to David Ford, the Executive Director of CalHIPSO, to close it out. Thank you.
Thank you, everyone, especially our colleagues at IHA and Gain for pulling this event together and making this happen. And for those of you who have hung in all the way through the presentation, oops, I went the wrong way there. Oh, there we go. Okay, sorry about that. If you like today's presentation, as we mentioned, this is part of a webinar series that CalHIPSO is starting. So next Thursday at this same time at the lunch hour, our next CalHIPSO webinar is about MIPS reporting for 2018. Our partner for that webinar will be SA Ignite. It was a company out of the Midwest who has really done some of the best webinars that we've seen on MIPS Year 2 reporting. There's a registration link there. And in addition, if you would like to receive ongoing updates from CalHIPSO about more events like this, please send us a note at info@calhipso.org. And I'll put one final plug. I hope everyone will circle on your calendar May 13th, 2019. It's a Monday. I realize it's a bit far out, but that will be the first ever CalHIPSO conference exploring health IT after meaningful use. As we mentioned at the beginning of the webinar, this webinar will be recorded. I know we got a few questions we didn't get to, so hang in there. We'll try to find a way to capture those and find a way to get a response to you after the webinar is done. With that, I believe we will close down today. Again, thank you everyone for attending today, and we will hope to see you on a later event.